that I consider this time to be the most important time we could ever talk about any topic. Of course, I don't know if you'll believe me or not, but the truth is that this time I'll show you with evidence that it's the most important one. It's the most important time we've talked about something clinical, something scientific. But I consider it without a doubt the most important one that you need to watch, need to learn, and need to make a part of your attitude: hand washing. With hand washing, if any other topic you learn saves one patient, if you're learning how to ventilate a pneumonia patient, for example, and you save that patient, then with hand washing, you might be saving 100 patients. You're saving all the patients. So it's an important topic, or rather the most important thing of all, and I hope you watch it repeatedly. All right? This time we're going to answer a very important question. It is how to ventilate the severe type of chronic lung disease. Of course, with evidence. Why is this topic important? Because to ventilate chronic lung disease, you need to understand all of ventilation. And by ventilation, I don't just mean the mechanical ventilator, I mean all respiratory support. Because the patient doesn't necessarily have to be on a mechanical ventilator. The chronic lung patient might be on non-invasive support, so it's essential to understand everything. They could be on microflow nasal cannula, CPAP, or any type of support. So you need to understand all respiratory support. If you haven't listened to the many times we've talked about respiratory support, it's essential to go back and listen to them so you can understand respiratory support and mechanical ventilation along with it. The second thing that gives this topic great importance is that you must understand the disease. You must understand what chronic lung disease is. That's why this is the topic. In other words, this topic will help you understand, or rather, it is the result of all the times we have talked about respiratory support, including, by the way, the graphs. Because an important part of the graphs talks about chronic lung disease, which is high resistance. So as we said in the times, we talked about the graphs. So that's why this topic is important. So let's look at the most important topic we can talk about. Welcome. The importance of this topic, or the importance of this session specifically, is that we will be saying something a bit different information, not from us, different information that already exists. It exists in books. We are bringing it from books, research papers, existing abstracts, and the information that is available. We aren't making things up or inventing anything. So it is new. Why is it new? Because many people don't know it. And if you tell them this, they will be very surprised. And I have seen this. I am telling you about something realistic. Okay, let's get to the important part. Okay, to ventilate chronic lung disease, you need to understand the ventilator and you need to understand the chronic lung disease. That's for anything, any patient. If you're going to ventilate the patient, you need to understand the ventilator and you need to understand what this patient has. For the ventilator, it is essential that you understand everything. All respiratory support, the graphs, and the modes of mechanical ventilation, so we know which mode to use with this patient. Okay, the second thing regarding chronic lung disease is that you must understand the definition of chronic lung disease. And you must understand the classification of chronic lung disease. This is all, a bit academic. I won't go into it much, honestly. But I will present it to you because if we sit here talking about this, we'll be here until tomorrow. But I have put together an abbreviation or a summary for you so that whoever wants to take a screenshot can have it in front of them, or whoever wants to read it at their own pace can do so. What will you find that I've included for you? I've included the definition and the classification. And I will also include the pathophysiology. The exchanges that occur in chronic lung disease from the upper airway all the way to the lower airway, and everything including the glottis, epiglottis, trachea, bronchioles, alveoli, and all of that. All right? And if I find anything else, I'll add it for you as well. After that, take a look at them, take a screenshot, and read them at your own pace. Let's talk about the practical side of things. Practically speaking, how are you going to ventilate this patient? The first thing we need to know is that we must remember this image very well. And I told you that I would bring you the classification of respiratory support every time we talk about any topic related to respiratory support. This classification is important. Remember it, know it well, and learn it just like any other important thing you learn. Which is non-invasive, invasive, non-invasive ventilator, conventional ventilator, high-frequency, non-invasive pressure, and flow. We said that whether it's this or that, it's either one level or two levels, and we mentioned the machines that perform each one of them. Got it? Okay, the second thing is I just want you to remember these three formulas. Three very simple formulas that we have taken many times, but keep them in front of you because they are very important. They are the guide for you to understand the subject. The first one and the first formula says that compliance, which is C, equals the change in volume over the change in pressure. And this is something, very classic, the classics. Compliance equals volume over pressure. And we've explained it, of course, not just once, but twice. But know it well. And we've said it a lot. And we said, what does this actually mean? What does C equals V over P mean? It means how much volume you will push into the lung by using how much pressure. If you used a lot of pressure and pushed in a small volume, then you have compliance very low. If it's the opposite, if you pushed in a lot of volume with low pressure, then you have very good compliance. Okay, that's the first one. The second one talks about the time constant, and of course, it was covered once on its own. What does it mean? You have to go back to it. Meaning, we said that K equals compliance times resistance, and we said before that this time constant is your guide for the inspiratory time. Meaning, a large time constant means you set a large inspiratory time, a small one means you set a small inspiratory time, and we explained all of that. Okay, it equals compliance times resistance. So what does resistance equal then? It equals the opposite. It equals the pressure, the change in pressure, times the volume. I mean, you see, they are all basically three factors. But these three factors, we change them sometimes by division, sometimes by multiplication, and so on. That's why the three are close to each other, and you must understand them all. So resistance equals the change in pressure over time, not over the volume. But here the truth is, when they said volume, they meant the constant. You have to keep the volume constant and then look at the pressure. If you have a large change in pressure, then you have high resistance. If you have a change, meaning you use low pressure to move a constant volume from one point to another, then that is low resistance. And if you are using a lot of pressure, then the resistance is high. This is important. All right, these three are very easy now. By the way, the work of breathing is the third one, because the work of breathing is important. The work of breathing, which is the work, it's called physical work, but since it's in breathing, we call it work of breathing. So the work of breathing also equals pressure times volume. But here the volume is changeable. I mean, in resistance, it is fixed. But in the work of breathing, what does it mean? What it means in the work of breathing. If you use high pressure, then you are doing high work. You want to do work, which is the force you need to exert to move this pressure. And if you move a large volume, then you are also doing a large amount of work. Okay, and this is important for the patient, so you don't make them do too much work by changing these two factors. Okay, these are three very important things. Now they've become four, no problem. Just be aware of them like that. You know, the fixed laws that we will use, and these are physics laws. Okay, just so we don't drag this out, because the topic is very big and there is a lot to say, and it would be so easy for me to just pull up slides and we sit and read them slide after slide, and you know that this is completely against our policy. So we will tell you what's useful. What's useful now is that in order to ventilate a patient, you need to know the disease they have. We have chronic lung disease. Why do you need to know the disease? To know the pathology they have, or the pathophysiology. In short, the pathology in chronic lung disease is equal to high resistance. That's it, because you only have two factors in the disease you are dealing with, which are compliance and resistance. Meaning, is compliance high or low, and is resistance high or low? That's it. And based on that, you ventilate. And that is why the ideal model for this is RDS. RDS is an ideal model for low compliance. That's why it gives you surfactant. Okay, and the counterpart to that is chronic lung disease, which is a high resistance model. And that's why we will ventilate it in a specific way. When you know it's high resistance, you go to the equation. It tells you that with high resistance, compliance might not change, but it's not a factor for us at all. We are dealing with resistance. So what will resistance tell us when it's high? You go back to the time constant equation, and it tells you that a high time constant means what? It needs a long inspiratory time. All right, that's basically the first principle of the matter. The second thing regarding the pathology of chronic lung disease, just remember them like this. You have the main pathology. The main pathology is that you have an area of consolidation and an area of hyperinflation, a hyperinflated area, and that's why it's scattered like that and heterogeneous. And this heterogeneous part is very important. This specific word, heterogeneous, will be useful for us in ventilation, just so I can tell you about it and get it over with. That's why high-frequency oscillation ventilation is not really preferred with chronic lung disease. Why? Because it is useful if you remember when the pathology in the patient is homogeneous, so that there is good distribution. That's why it won't be good for us. But there's no harm in trying it. Anyway, that's just a quick point. Okay, so our main pathology is resistant. What does that mean? It means the patient needs a long inspiratory time. So what does resistant actually mean? Note that resistance shows up during expiration. So to have good expiration, you need a long expiration time because you have high resistance. I will show you the graphs that demonstrate resistance and air trapping. Here is what resistance looks like in all the graphs. And we just mentioned it a couple of times. We talked about this beautiful, very beautiful slide that has all the graphs showing high resistance. If you look at them from the flow curve to the volume pressure to the flow volume, they all show the shape of high resistance. And here is the air trapping, which is very clear in what? The flow volume loop is very clear. And we mentioned the difference between it and air trapping, just so you remember. Okay, what's next? The next important point regarding the graphs is that you need to know and remember what we said before. And we said that the inspiratory time affects the volume, the tidal volume. So when you provide a good inspiratory time, it allows you to deliver a good volume, a good tidal volume. If you make it short, it won't deliver enough tidal volume. And here is the slide that shows what? That when you increase the inspiratory time, it delivers enough volume to the patient, enough tidal volume. Okay, these are the graphs that you must be familiar with. Now let's go back to this topic. Let's go back to the pathophysiology that happens in chronic lung disease, which are two things: high resistance, and you have an area of consolidation or collapse. Well, consolidation doesn't mean inflammation here. Rather, it is an area of collapse and an area of hyperinflation. This is the main characteristic pathophysiology in chronic lung disease, especially the severe type. Okay, what does this mean? It means that you have two areas that need different modes of ventilation, different strategies. I mean, if you are ventilating the hyperinflated lung in a certain way, and if you ventilate the collapsed lung in a different way, a different strategy, I mean, in the settings, but you have both. And that's why that very important theory came out, which says that when you ventilate chronic lung disease, you are doing something called two-compartment ventilation, meaning you are ventilating two different compartments. And I'll tell you the people who developed it and so on. Their names are, I think, Neil and Castle. So credit should be given where it's due. Okay, and this is a very important theory that we will use. So let's start with the settings. What should we say first? We've understood the pathophysiology and we've understood, let's talk about the mode. What is the mode that you will use? What is the best mode for severe type chronic lung disease? The first point, as we just mentioned, is that high-frequency oscillatory ventilation is not the ideal mode for chronic lung disease because it is a heterogeneous pathology, and this is not the ideal pathology to ventilate using high frequency. Got it? However, because the situation is so difficult, we are forced to try high frequency because you are failing with all the conventional modes. If you have failed with all of them and can't find a solution, you might try it. It might turn out to be good. Got it? That's the first point. The second point is that there is no recommended mode. The mode depends on the patient, the clinical condition, the blood gases, the x-ray, and everything else. There is no single mode. And here the most important figure in chronic lung disease is called Bancalari. He is a well-known American man who has been working on chronic lung disease for a long time. And I met him at the conference that was held recently. Honestly, he also gave a lecture on chronic lung disease and held a workshop on chronic lung disease. And his entire work is, and the truth is, to summarize his words, the subject is very difficult. Bancalari says that this is a very difficult subject, ventilating chronic lung disease. And anyone who has worked on or tried chronic lung disease ventilation will understand what Bancalari means, because it is truly difficult. But I mean, I tried to ask him direct questions so we could get something out of him, but we didn't get anything. I mean, they were having a dinner called a gala dinner. They always do it at conferences, like on one of the conference days. They hold it at night around 7 o'clock. A nice dinner and a pleasant atmosphere. Everyone meets up, sits down, talks, and it's a lovely atmosphere. Anyway, so he came and sat with us, and I spoke to him frankly. I asked him, what is the best mode to ventilate chronic lung disease? He said to me, I don't know. And of course, he told me I can't name one mode for every patient. The mode must be specialized for each specific patient. There isn't one. So you have to, well, okay. What does that mean? It means that when people are truly knowledgeable, they are humble, they can say, I don't know, and it's not a problem. This is the number one person in the world talking about chronic lung disease. Okay, we don't want to dwell on this subject. We said before, be ignorant rather than be a criminal, We talked about it in a bit of detail. Okay, let's go back to chronic lung disease. Okay, what does that mean? It means you can use any mode. Here are the different modes that we use, but maybe a little bit, you could use SIMV. You could use SIMV with pressure support. You could use AC. You could use pressure support ventilation, and we can use VG with all of them. All right? So really use whatever God guides you to use and whatever you understand well and whatever works for the patient. Okay, but the most recommended to some extent is that people use SIMV with pressure support and VG. Okay, now let's get to the main idea. All that previous talk is common, and these points are common again. What does that mean? What does it mean? What setting will you put on the ventilator? You chose SIMV with pressure support with VG. So what next? Based on the pathology we've learned and the pathophysiology, we will say the following. You want to ventilate the lung, and remember the two-compartment ventilation theory. What does that mean? It means you have collapsed areas and hyperinflation. So what do you want? You want a long inspiratory time to open up the collapsed area. And at the same time, you want a long expiratory time. To do what? To evacuate the hyperinflated area. Otherwise, you will cause air trapping. How will the evacuation happen? With a long expiratory time, it evacuates the CO2 from inside. Okay? Well, that's a strange thing, right? I mean, you want both of them to be long. So how are you going to get both of them to be long? Again, let's remember that we have 4 factors that affect each other, and they are important. If you change one, the rest will change. What are they? Inspiratory time, expiratory time, rate, and the inspiratory-expiratory ratio. Got it? These 3 are one package, and we've mentioned them before. Okay, so what are we going to do now? We want a long inspiratory time and a long expiratory time. This can only be achieved with a low respiratory rate. Why? It won't happen unless you lower the rate significantly. The recommended rate for chronic lung disease is, imagine, from 15 to 20. Of course, this number is terrifying. If you tell anyone, they'll be shocked by you, I mean. Speaking of shock, that is. But this is the truth, this is the reality, this is what is written, because you won't be able to adjust the settings or get the optimum settings for the pathology you have, except with this rate. But keep in mind, to do this, you must do it gradually. It must be gradual. You can't just have him on 50 and then go and give him 15. So this is the management part. And in chronic lung disease, this is chronic management over months. They even write over years. That you make the change gradual, but it must have a plan. You need to understand where you are going, and you should be guided, of course, by the X-ray and the blood gas, as we said, and the clinical condition, which I will tell you about. Okay, that's the first thing, the rate. So are you going to reduce the rate a lot? Let's take a rate of 25, just to be in the middle between these and those. Not in the middle to please them. No, in the middle as in we are in the middle of the management plan. Meaning the patient was on 40, for example, and we started reducing it little by little, 5 every few days, until we reached 25. And we have a plan to reduce the rate even further. Okay? Okay. Speaking of this rate, you'll find a very important point, a very important question I was asked when we were discussing this topic. It's necessary for me to tell you because it's important, as it might cross someone's mind. What if the patient is breathing? You'll be using SIMV with pressure support, and therefore, or AC or PSV, all of them will support the extra breaths. So if you set the rate for the patient at 20 or 25, but they are breathing at 50 or 60, then what's the point? We haven't achieved a low rate, so all of this is useless. No, the answer to this is another question. Why is the patient breathing fast? Because they are not ventilated properly. What does that mean? It means not optimum ventilation. You are not giving them a good tidal volume, so they are forced to increase the minute ventilation, increasing the rate to improve the minute ventilation by increasing the rate because they have a low tidal volume. Got it? Minute ventilation is tidal volume times the rate. Got it? Okay, but if you put them on this setting, meaning you gave them a high tidal volume and a low rate, it will be optimum for them. And even if you start this, they will start while they are still tachypneic, for example, at 60 or more. After that, little by little, they will come down on their own. But that doesn't mean that just because they are taking a high rate, we should leave them and give them a high rate. Got it? Okay, so this point is important. So we need to provide a low rate, and at the same time, we need to provide a significantly increased tidal volume. Why? To compensate for the low rate, because you still want to achieve the minute ventilation, and you will not achieve the minute ventilation unless you either increase the rate or increase the tidal volume. So since you reduce the rate significantly, you must increase the tidal volume significantly to the point where, well, the normal tidal volume, as we said, is 4 to 6 ml per kg. So you need to start from 6, and it could reach 8, 10, or even 12. Imagine 12 ml per kg, that's double the normal. Okay, and we've already mentioned the rate. As for the inspiratory time, the normal, very normal inspiratory time, let's say, is 0.4. But here they start from 0.6 up to 0.8, also double. So almost everything is doubled. Okay, and for PEEP, you need to provide high PEEP. Let's not always call the pressure high or low. Let's call it optimum. So you want an optimum PEEP to what? To maintain the lung well inflated and recruited, because you have an area of collapse. So you need to inflate the lung well or get it semi-inflated. I mean, by using good PEEP. What is the guide for good PEEP? Its guide is very important. 3 things: the clinical condition, the X-ray, and the blood gas, or rather the oxygenation or the FiO2. Why? First, the X-ray, to see the lung inflation up to what point. So you increase the PEEP, they start the PEEP from what? Let's say from 8, they might even reach 12 PEEP. And some people used to do 14, which is a terrifying PEEP. But I mean, they start like this. What's the starting point for chronic lung disease? 8, and then you go up depending on what? Depending on the X-ray, you see if it's hyperinflated or hypoventilated. You might give a PEEP of 10 and it's still hypoventilated, meaning there's an area of collapse, so you're forced to increase it. Okay, what else? The clinical condition. The patient who has good PEEP inflation doesn't fight the ventilator. They are comfortable and synchronized with the ventilator because they have good inflation and don't have air hunger. Low PEEP causes them air hunger. What's the third thing then? Because it increases their functional residual capacity, and we said before that when they have good functional residual capacity, their breathing improves and there is good synchronization. The third thing is that regarding oxygenation, if we say increasing PEEP improves oxygenation, then they will have a lower FiO2 and good saturation. The attacks of desaturation become less frequent. This is important because it affects the patient's neurodevelopmental outcome, and this is one of the things we must look at carefully. All right, that's PEEP. So what PEEP should we use? For PP, they tell you to also use an optimum PP, but it shouldn't be too high, so you can avoid barotrauma. But you use PIP to the extent that achieves the tidal volume you want, but it shouldn't be excessive. And if we use VG, it controls this issue because you set the P max. Okay? All right. The ratio should be different. Normally, the ratio should be 1 to 2 in RDS, for example. But in chronic lung disease, it could be 1 to 4, 1 to 3, 1 to 4. Meaning, what does a large ratio mean? It means that the expiratory time is very long in order to wash out the CO2 to avoid air trapping because you have very high resistance. Okay, so that's the inspiratory time. And as for the FiO2, it depends on the patient and the target saturation. Again, it's important to remember that you can't just change these settings suddenly. You can't just come in and say, I understand chronic lung disease, and then go into the unit and change all the settings. If they have a rate of 50, you shouldn't just change it to 20. Or if they have a PEEP of, say, 6, you shouldn't just change it to 10. Okay? The process is gradual. It should be gradual, guided by the X-ray, blood gas, and the clinical condition of the patient, and by the improvement and the response. So it's necessary to do it, but the aim must be clear, the strategy must be clear, and you must know what you want, what the pathology is, what the patient's clinical condition is, and what the underlying pathophysiology is. Got it? These are very important things. You need to understand that there is something called two-compartment syndrome. You need to ventilate 2 types of pathology present in the lung. The next point is that most people, or the prevailing idea among people, is that their primary concern is weaning. And this is something that is, of course, well known. The thing that occupies you the most is that you want to get him off, the respiratory support he's on, to remove it. This shouldn't be the concept in chronic lung disease. The concept must be different. You need to know that you are ventilating a chronic patient who will be there for weeks, months, and years. So the idea must be different. What kind of idea then? That your main job should be to optimize respiratory support instead of being preoccupied with weaning and reducing respiratory support at the expense of oxygenation and proper ventilation. So this is a point we must take into account. You must know that an ARDS patient has a different concept in ventilation compared to a chronic lung disease patient. Completely different numbers. Different concepts, different modes, everything is different. The next point is that if you want to ventilate with high frequency jet ventilation might be better than high frequency oscillation ventilation. And God willing, we will have a time to talk about jet ventilation if we live long enough. So this is an important point. But if you are going to use conventional, it will be better than high frequency oscillation, and you will try to, they tell you to tailor what? the best mode for the patient, and the best setting comes gradually. I will show you another video filmed from a real patient. I filmed it myself from a patient who has a severe type of chronic lung disease. I have included the two loops in it for you. The loop, which is the pressure volume loop, and the other, the flow volume loops. And you will find in it, there are the characteristics of the things we mentioned regarding high resistance. You will find them very clear in both. You will find that the main pathology in chronic lung disease is sometimes written as a decrease in compliance. The meaning of compliance decreasing is that the time constant should decrease, meaning you should use a short inspiratory time. But you must understand this point very well, because I wanted to say it separately to avoid any confusion, that the percentage of compliance decrease is very small, meaning the change in compliance is very minimal, but the change in resistance is very prominent, meaning it is very noticeable and large. That's why the high resistance will overcome the minimal decrease in compliance for chronic lung disease, which is actually mixed because you have two compartments, so they could form different compliance, and that's what exists. Also, the functional residual capacity will decrease, and something called forced expiratory flow will also decrease, meaning for it to exhale. Why? Because high resistance, as we said, is very apparent during expiration, not inspiration. The resistance shows, so the flow decreases. That's why you must give him a long expiratory time. Okay, there are just a couple of words, a nice paragraph or slide that summarizes everything we've said. It's very important. You can also take a screenshot of it because it's very expressive and summarizes everything. I mean, the whole idea isn't just for you to simply remove respiratory support. It is very important that development is good. And you must also know that the management of chronic lung disease, of course, there is no consensus on it. I mean, every unit has its own protocol, and that's the idea. Secondly, management isn't just about you removing respiratory support. No, management includes a very important nutritional factor. Growth is also important in this. The other factors, if you want to use diuretics, inhalation, or steroids. These are other factors in the treatment, but what concerns me this time is the ventilation respiratory support that you will give to the patient. Another important point is high-frequency nasal cannula, and we mentioned this before in the classification of respiratory support. So that when we mention it, or you hear it anywhere, you know where it fits in the classification, you know its position and what it's used with. The whole idea is that it came up here with chronic lung disease, the high-frequency nasal cannula, because its effect is being compared with the non-invasive method. The non-invasive, which is the nasal intermittent, which is the 2-level pressure, and they are also comparing it with the regular level, meaning the 1 level. So they found that it is almost equal and could be an alternative method to what? The nasal intermittent, that is, but it is superior to the 1 level. The 1-level CPAP is slightly superior because it improves the it washes out carbon dioxide better and can perform better lung recruitment. So it is one of the alternative ways that you can use for respiratory support. But for non-invasive respiratory support, when you want to succeed in extubating that patient from mechanical ventilation and move to non-invasive, you can indeed start with nasal intermittent with 2 pressures because they are high, but